Hi, this is Lucy Sullivan interviewing Dr. John Ebersole on August 28, 2012. Dr. Ebersole, when and where did you receive your degree, and where do you currently work?
I received my medical degree from Yale University in 1971. I'm currently working at the University of Chicago and at the Illinois MEG Center at Alexian Brothers in Elk Grove Village.
What drew you to EEG and diagnostics?
Well, when I was in college, also at Yale, I was very interested in the brain. The brain was the sort of the last frontier. Very little was known about it, and I was a psychology major doing experimental psychology, and one of the professors there, a man named Robert Galambos, was beginning to do some interesting electrical recordings in animals called evoked potentials. And this was rather new at the time. This was back in 1966 or so. My initial work in neurophysiology in animals led me into neurology, and my interest in electrodiagnostics continued, and EEG and clinical neurophysiology was an obvious choice given my early interest and work in neurophysiology.
Was EEG a popular specialty when you were starting your career?
It was. I mean, back in those days, EEG was really at the forefront of neuroscience. The microelectrode work and in vitro work had really not begun yet, and studying the whole brain function in animals and humans was the way to go. So at that time, most of the scientists in neurophysiology were electroencephalographers, or were studying whole brain function in both animals and man.
Who were your early mentors?
Well, I mentioned one. My first mentor was Robert Galambos. He was professor of psychology, experimental psychology at Yale, and he was one of the pioneers in auditory evoked potentials. I did my undergraduate thesis with him, and then in medical school, he moved to University of California, San Diego, and I went out there in the summers and did my medical school thesis with him on visual evoked potentials in cats. After Dr. Galambos, my next mentor was Cosmo Ajmoni-Marsan, who at the time was running the EEG branch at the NIH. And between medical school and residency, I spent 3 years at the NIH in the Public Health Service in his laboratory, and it was there that I learned how to do microelectrode work, and I began to study single cell response in the penicillin model of epilepsy. After my 3 years at NIH, I did my residency at Yale, and my next mentor was Gilbert Glasser, who was electroencephalographer, was president of the EEG Society and the American Academy of Neurology during his career, and he gave me a laboratory to work in there at Yale as a resident, and also the unusual position that I began reading EEGs clinically as a resident rather than a fellow. So those three individuals are really my principal mentors.
What were your earliest career influences?
Well, pretty much as I said, both my interest in brain function, in experimental psychology, and then the mentors that I had sort of led my path into neurology and then into clinical neurophysiology.
If you had not become a physician, what would you have liked to have done?
Well, back at the time when I finished my college degree, when I was working with Galambos in his laboratory, there was the option of going the PhD route or the MD route. So I decided to go the MD way because I thought it offered more options than becoming a PhD. I could be both a scientist and a clinician. If I became a PhD, I could only be a scientist. So had I not become a physician, I probably would have been a PhD neurophysiologist.
Why do you think this field took off when and how it did?
Well, as I said, in the 50s and the 60s, EEG and whole brain physiology was really at the forefront of neurological work. Unfortunately, I think in the 70s and 80s, when in vitro work became more popular, there were still many questions about whole brain function and EEG, what it meant, where it was coming from, substrate of it, etc., that really were not answered, and many of them still are not answered because the focus became microscopic rather than macroscopic. At the same time, and we'll probably talk about this a little bit later, I think EEG unfortunately did not progress as a science and became more of an art. And I think some of that problem still exists today, that people are not thinking about it as scientifically as they should.
What equipment did you train on, and what were the main limitations of it?
Well, I've been around for quite a while, and when I started my clinical work, an 8-channel GRASS EEG machine was pretty commonplace, pen writing machine. And over my years, many things have changed. The first, 16-channel machines, and then more channels, and then finally the digital revolution in the 90s. On the evoked potential side, I remember the very first experimental evoked potential machine was called a Cat Nematron 400, and it was special because it had 400 data points that it could remember, so that you could do evoked potentials and you could average them. That was the first time you were able to average evoked potentials with only 400 data points. Nowadays it would be laughable, but that was really a big deal. And by the time I finished my medical school work, we had 1,000 data points. We had a computer of average transients that had 1,000 data points, compared to the spectacular digital equipment that we have today. Those were the good old days. I remember one other thing I will say is, as far as epilepsy monitoring is concerned, now we have 128, 256 channels, digital video, etc. When I first started out, we had an 8-channel GRASS EEG machine with a video camera pointing down at the paper, so that the long-term monitoring recording was a video recording of the paper coming through the EEG machine. That was quite primitive compared to systems nowadays.
What memories do you have of your training?
Good memories, and each person was different. Galambos was an interesting person. He had a philosophy that until you knew how to do everything yourself, you would have no help. But once he knew that you knew how to do something, he could give you help. In other words, I had to first learn how to build amplifiers before I could use the equipment, and I had to do my own histology on brains, before I could have help on that. I had to do my own photography before I could have any help as far as publications are concerned. It was really a good training because by the time I got to NIH, I knew how to do everything myself from the beginning to end of an experiment, which was very good. I have good memories about Cosmo Marsan, who had a very different approach, very laid-back approach. And he said, here's your laboratory, here's a bunch of equipment, think about it for a month and then come back and tell me what you're going to do. And so fortunately, having been trained with Galambos, I knew how to do things, but it was the first time I was told, go off and think about something and come back and tell me what you're going to do. So there was an interesting freedom there. Similarly with Glasser, I had the freedom to do what I wanted to do, but by that time I pretty much had decided that I was going to work on the neurophysiology of epilepsy. And in the clinical sphere, the two mentors that I didn't mention previously came into play, and that was Dick Mattson and Peter Williamson at Yale. They were the people who started the West Haven VA epilepsy monitoring unit, which was one of the first in the country. And I remember learning with them, particularly how to read long-term EEG with paper. We had a long corridor, and I remember we used to put the paper on the floor so that it would stretch for 50, 60 feet. And that way we could sort of walk along the paper and see the EEG abnormalities, particularly seizures, more clearly than we could on any single page. And in fact, that's something that's very difficult to do nowadays. It's very difficult often to see the perspective of a seizure on a single screen as opposed to spread out, 20 or 30 feet on the floor. So I have lots of good memories of things that happened over time.
What are the main ways in which the field has changed over your career?
Well, lots of things have happened, particularly in the technical side of things. I mean, going from a few channels of 10 written EEGs to now wonderful digital systems of hundreds or thousands of channels that allow you to analyze data much more thoroughly than you ever could in the past. I think the digital revolution was really the biggest thing that happened, and the sad thing I think today is that many electroencephalographers are not taking anywhere near full advantage of the capabilities of the digital systems. But I think we'll get to that in some of the later questions.
How has scientific knowledge changed the field, and what do you think were the big breakthroughs?
Well, I think at least recently, certainly with the advent of the digital equipment, we have the capabilities of thinking about EEG now in terms of electrical fields on the surface of the scalp, how they're related to electrical fields in the brain, and then how those fields are related to sources of this activity. Certainly, with the new equipment, we have the capability of trying to determine or predict where these sources are coming from within the brain, what the character of what the fields are. This really makes EEG much more scientific and less of an art form. It allows us to go beyond simple pattern recognition to try to figure out the underlying source of this activity, which is very helpful, particularly in epilepsy, where trying to determine where the epileptic focus is in 3D is very important for epilepsy surgery candidates.
What are the 2 to 3 big issues in EEG that people are working on to solve today?
Well, as I say, I think one of the issues is source localization. It's no longer adequate to say a person has a T7 spike. That's meaningless. The whole concept is where in the brain is that coming from? It's not necessarily just coming from underneath the electrode. The whole concept of three-dimensional EEG and source localization, I think, is very important. It is an offspring of voltage topography, and voltage topography means thinking of the EEG not in terms of wiggles, but in terms of the voltage fields over the head, the gradients of those fields, what they mean, and how they relate to the source. The other big issues relate to the spectral content of the EEG, the frequencies. We know now that there are many frequencies beyond the Berger band, if you will, both in the infra-slow activity and the ultra-fast activity. There's a wide spectrum, no pun intended, of data that are not being utilized, that carry important clinical information, and we're just beginning to do that as well.
What are the main areas of professional discussion or disagreement today?
Well, I'll take the disagreement the concept. There's still a problem in how one goes about interpreting a clinical EEG. It's funny. It's been years, since we've had the capability of viewing the EEG in any way you can. Yet there are still some people, some places, who will only read an EEG in one montage and not another montage. Will not take advantage of the capabilities of a computer to take the raw EEG data and display it in any way you want to. There are people who still refuse to. There are people who still follow the guidelines for EEG when we only had 10 written records, even though nowadays we have digital records. And the restrictions that you had with pen EEG are no longer there, yet they still carry on the same policies with digital EEG, which doesn't make any sense. There's still a lack of understanding about the impact of the reference, for example, on the EEG. There's still people who believe that a referential recording will not adequately or will introduce artifact into the EEG that is not real, or will show sources that were not real. There's still people who don't understand the fact that for every negative discharge or potential within the brain, there has to be, by physics, a positive side of that. The only dipole that's usually talked about in standard EEG texts is that associated with benign Rolandic epilepsy, when in fact every single epileptic spike produces a dipolar field if you look for it. People are still concentrating on the phase reversal in bipolar EEG, which is simply a sign of the negative field maximum, whereas they pay no attention to the positive field maximum, which is just as important and is totally necessary if you want to try to localize these things. So there's a lot of and there's still a lot of people who depend upon pattern recognition rather than trying to understand the nature of the source to produce that pattern. So there's still a lot of art that needs to be converted into scientific understanding.
What are you most proud of in your professional life?
Well, I'm proud of having done 4 things that I think were pretty important. Very early on, I think I did some really good work about cellular abnormalities in epilepsy, in particular certain um, epileptic models. Then when I went into the clinical sphere, I'm proud of three things. And it's because I didn't create or develop I didn't discover these things, but I think I played a major role in their evolution into clinical practicality. The first was the ambulatory EEG. Way back in around 1980 or so, this little device came on that everybody was laughing at. It was a little recording device that could record 3 channels of EEG. Everybody laughed. What in the world are you going to do with 3 channels of EEG? But over time, I proved and I showed that even with 3 channels of EEG, you could gain useful information by monitoring patients at home with these devices. And then it evolved into 8-channel devices and et cetera, et cetera. So until nowadays, ambulatory EEG is considered a major practice tool. But back when it started in the early 80s, I had to convince a lot of people that with 3 or 4 channels of EEG, you could get lots of useful information. The second thing in the clinical sphere that I'm most proud of is to bring into clinical utility voltage topography and dipole modeling. Back when the computers came on the scene, we first had the capability of producing maps of the voltage on the head. Unfortunately, some people very early on went to extremes and thought that they could diagnose psychiatric disease and other sorts of functional disorders with these brain maps of pretty colors, etc. And that really set back scientific voltage topography 10 or 15 years. So it was only in the early 90s that I began doing some work showing that the voltage topography could separate types of spikes that had a relationship to where the source of the spikes was, to whether or not a person was a good surgical candidate and that sort of thing. And voltage topography led on to dipole source localization, which was the next step, taking these maps and predicting where the source would have to be in the brain that produced that source. So now voltage topography and dipole modeling are clinically accepted. The final thing that I'm proud of is doing essentially the same thing with MEG. MEG was an interesting technology, but how to use it properly in the diagnostic areas really wasn't developed. And importantly, how to use it in combination with EEG. So my big message now that I'm trying to promote is the fact that EEG and MEG together are better than either alone. They have complementary strengths. They make up for the weaknesses of the other. Doing either alone is not as good as doing both together. So that's my big push today.
Where do you see neurodiagnostics in 10 years?
Well, I think, as I said before, there's going to be continued progress in a number of areas, particularly in advanced analysis of the EEG, both in terms of voltage fields and source localization, and also in terms of spectral content. I think we're going to have machines capable of a much more detailed analysis of EEG, bringing it into the 3-dimensional area and merging it with imaging techniques of MRI, etc. I think the age-old desire for 3-dimensional EEG will be commonplace.
What is the best piece of advice that you've ever received?
It's hard to say, but I don't know if it's advice, but a piece of common sense that I like to use and to tell people is when when you're looking at data, the EEG or whatever, if something doesn't make sense, it probably doesn't make sense, and probably something is wrong, and you need to go back and check how things are connected, what's going on. I remember a story. We had built this big interface box for 128 channel intracranial EEG, and it had been used for a while by some of the other attendings, and then finally I got to use it on this patient, and I was looking at the EEG, intracranial EEG, and it just didn't make any sense. It just didn't make any sense. The fields were not correct or whatever, and I was so convinced at this that I went back and tested, with an ohm meter, the connectivity of this box, and realized that the box had been wired wrong. That what was supposed to be connected to what wasn't, and that people had been using this box clinically for months before I did, not knowing that it was wired incorrectly, and not paying attention enough to the fields to know that it didn't make any sense. So I keep telling that to my people. If it doesn't make any sense, it probably doesn't, and you need to figure out what's wrong.
Is there anyone else in EEG and neurodiagnostics you think I should be interviewing? Who could you recommend?
Well, there are a couple of people that I think are pretty senior and have had interesting careers. You probably know them. In Canada, there's a very senior electroencephalographer named Warren Bloom. And Warren is a very clinical person. He has a lot of experience. He doesn't do as much scientific sort of analysis that I do, but he's very experienced. And also in Canada, there's a PhD who has done a lot for the field of EEG, and that's Jean Gottman at MNI. Although a PhD, he has really done a lot to advance the field of EEG.
And I have interviewed Dr. Gottman.
Oh, you have? Okay.
Yeah. And Dr. Bloom, he recommended Dr. Bloom too, so he's on my list. So good. Yeah, no, Dr. Gottman was really. I've never met him in person, so it's really interesting to interview him. But yeah, and it's interesting to interview him and Pete Seba, who's an engineer. Just they come at it from a different viewpoint, kind of, than other people. So it's really interesting to hear their stories too. Well, good. Well, thank you.
You're quite welcome.
I really enjoyed it. I remember because my first job was in Illinois, so I'm sure I heard you speak often on ambulatory EEG. That's what I remember at like central meetings and different things.
Yeah.
Yeah. And I really enjoyed your talk on MEG. That was I learned so much.
Great. I'm glad.
I like the clinical, because I've read about it, but I've never done it or even sat in a lab where they've been doing it. And with your clinical cases, it just really taught me so much that way. That was really excellent for me anyway.
Great. I'm pleased.
A great way to learn. Well, thank you so much for your time.
You're quite welcome, Lucy.
And we'll be talking. Bye.
Okay. Bye-bye.